Hey y'all, hey, it is Dr. Cherry, and today we are going to be discussing Chapter 6, Risk Assessment and Intervention, Suicide and Homicide of Jackson, Cherry, and Erford Crisis Assessment, Intervention, and Prevention textbook. All right. So we want to jump right in and start with suicide and homicide. So the first thing that people need to be aware of is suicide and homicide is a preventable public health problem, right? And so this is something that everyone needs to know when we look at, how suicide and homicide are looked at, especially we're going to start with suicide, but both of these are preventable public health problems. It's a preventable death and it affects everyone. So when we look at suicide and homicide, when someone passes, it doesn't just affect the person that passed, but it affects everyone. The first responders, the counselors who have to console the loved ones, the family and friends. And so suicide and homicide, three important things you need to know is that it's a preventable public health problem. Both of these are preventable deaths and they affect everyone. And so let's look at the statistics. Suicide is the 10th leading cause of death across all ages, according to the CDC in 2015. The 10th leading cause of death across all ages. They have it broken down in the textbook. Children ages 10 to 14, catch this, it's the third leading cause of death. Children ages 10 to 14, third leading cause of death. Youths age 15 to 24 is the second leading cause of death, right? These stats are crazy. Young adults 24 through 34, it's also the second leading cause of death. Adults 35 through 44, it's the fourth leading cause of death. And adults 35 through 54, it's the fifth leading cause of death. In all groups, in all these age groups, there are more suicides than homicide. And so you have approximately 12 youth die a day by suicide. 12 youth will die a day by suicide. However, for every successful suicide, there's between 100 to 200 attempts. So there's a few things I want you guys to be aware of. There's a couple of words, especially incidence, rate, cause of death, and ranking. So the term for incidence it's a nominal figure that states literally how many lives were lost by suicide than any other form. So the stats I just showed you, that's the incidence. It's a nominal figure that states literally how many lives were lost to suicide than any other form. And then you have rate. Rate is a value explaining data that has been interpreted by leveling a playing field statistically. And so what the rate does is it levels the playing field. If everybody had 100 people and, if 5 of these people died, then, there's a 5% rate. So that's how they do the rate. And then the cause of death ranking it's a cause of death ranking is often illustrated in a chart form that has the listing of the 10 highest deaths per cause, right? And so then you have the epidemiologists, and those are the people who study the cause of death, right? And so when you have an epidemiologist, he's going to study why did these people die? Did they die by suicide, by homicide? So those are the people who would determine that, the epidemiologists. And so if you look at this chart, this is a chart from 2018. It's a cause of death chart. And we just talked before that the cause of death chart is usually in a table format. And so you'll see in this chart the ranking. You'll see the 10 leading causes of death by age group. And this is a 2018 chart. And so you'll see, here there's homicide. Homicide is in red. You have suicide in green. Unintentional injury in blue. And there, of course, there's other things, the flu, heart disease, neoplasm, complicated pregnancy, all these. But usually what's ranking at the top beyond unintentional injury is suicide and homicide. So you always want to pull out your chart and know the age ranges and how they're ranking and what's going on with things like that. Okay, you can find this on the CDC website. So then we're going to look at prevention. So you have prevention, intervention, and postvention, and you will need to know all three of these subcategories. When you look at prevention, the goal is for zero suicide initiative. The goal is to prevent people from, wanting to kill themselves. And so how do we get to the point to where we talk to people and let them know their lives matter, right? These three intertwined parts, these are the parts that mental health professionals will have to look at. You want to talk to somebody regularly and frequently about, their life and, how important and how valuable they are and how important and valuable life is. I mean, that usually when someone's at the point that they want to commit suicide, it can be a buildup of things, but it's usually something that's really pressing. So you want to prevent them by getting them into some good talk therapy and maybe even, a psychiatrist medication plan. And then you have intervention. Intervention is when a person is there. They are literally at the point. They can be low, moderate, or high risk clients. They can be acute or chronic. They can say, yeah, I just feel really helpless and hopeless. Or they can be like, no, I have a gun and 3 bullets, and I'm going to wait until I send my kids to school, and then I'm going to come home and I'm going to go ahead and take care of that. Right. And so that's when we would look at the intervention. They have an actual suicide plan. And so you always want to be extremely present. Don't take things that your clients say to you lightly. And especially in crisis management, you definitely don't want to take something lightly that is said on the spot. If they just say, I should have swallowed a few more pills, or I should have jumped, as soon as, I felt threatened. You want to be there, and you want to be present and aware, and you want to know the difference between low, moderate, or high risk clients. So a client that says, I feel hopeless, maybe a low to moderate client. Like I said, a client, I just used the example of a client who actually has says I have a gun at home, 3 bullets, and I'll wait till my kids go off to school. That's probably a high risk client. They're probably really, really there. And then you have postvention. Postvention is usually those who attempted suicide or those who are successful, and you have to follow up with the family members. And so that's a really challenging place to be in postvention. Postvention, when you're trying to, be with the family and give them hope and encouragement, try to get them away from self-blame and things like that. And then those who have seriously attempted suicide, like they, took quite a few pills, they just happened to not die, or they, actually tried to hang themselves when somebody came early. And so you have to then do a lot of postvention. What got you to this place? And how can we make sure you never get to this place again? And so whenever you're dealing with a crisis management, and especially suicide prevention, you want to have resources. And so the Substance Abuse and Mental Health Services Administration created this suicide prevention facts. And so these kind of charts are something that you should have in your arsenal, in your toolbox, something that you should be aware of, especially the age ranges. And the biggest thing is you don't want to minimize. Right. And so if you have a client that's giving you all the warning signs, they're talking about wanting to die. They're talking about wanting to kill themselves. They're talking about feeling hopeless and having no reason to live. They're talking about feeling trapped. And so you need to be mindful of when you hear, especially when you're talking to children. If a child is telling you how bad things are, what you can't say to them is, oh, it'll be okay. You got to do your due diligence as a mandated reporter and make sure that client is taken care of. And the biggest thing you need to do is follow up. Right? You have to be mindful to follow up. All right. So we talked on the other side about acute risk versus chronic risk. So let's look at the two. When you're looking at acute risk, you're looking at something that's immediate, right? It's going to happen with 24 hours or less. They know the plan. They're going to do this. They feel that they just cannot keep going. They have just experienced the worst thing ever. They, caught their loved one in the bed with somebody else, and they're just experiencing some unbearable pain, or they just, found out their child was murdered and they just can't keep going and living this unbearable pain. Anything can be this immediate period. And that would be an acute risk. So it gives you, somebody is talking like within immediately 24 hours or less, I am going to go ahead and make life easier for me by not living this life. And then you have chronic risk. A chronic risk client is someone who's going through long-term patterns of dysfunction. And so maybe they were once on drugs and they relapsed, or they feel like they keep getting into relationship after relationship and it keeps going bad, or they feel like, you know, their parent just keeps abusing them and then says they won't, or even a spouse, they say that the spouse is going to stop hitting him and doesn't. So this is a long-term pattern of dysfunction, and they're at this point where they just don't care anymore. Like they're just done. Like they're done. They just really want this to end. And so that's when you look at, is this an acute client or a chronic client? The only saving grace with a chronic client is that you can probably do some prevention counseling. You can do some counseling and talk to them through, do a lot of narrative therapy and talk them through what they're going through. Acute client, they're probably in such a place of crisis that you're really going to have to be present and on point, right? Do not minimize any of these. And so to the acute and chronic, there's levels. There's a low, moderate, and high. You know, is the person just experiencing a lot of heartbreak and they're just feeling sad? You know, that may be low, but even low, you don't want to minimize it. And so you want to go through, is it low? Is it moderate? Is it high? Is it something that I can help them through? Is it something that we need to have them admitted for? Is this a 1013 kind of issue? And so if you have your textbooks and you look at page 163, it gives us a chart of indicator levels. And so, for instance, very low risk. You know, if you ask them, well, what's your plan? What's your plan to commit suicide? And they're like, yeah, I don't really have one. I just don't want to live anymore, you know. Or I'm just, you know, I just feel like I just want to give up. That may be a low, their thought of suicide isn't a full on out thought. They're just feeling helpless and hopeless. But if they say, yeah, no, I already got some rope from Home Depot, and the rope is strong. I know where to hang it from. We got this beam on our ceiling that's sturdy. You know, I've already weighed myself. I know I can hang on there. That's probably a high risk client. And so you want to be aware of that. Moderate is like, you know, I'm just going to drink myself into a stupor and, you know, just hope I don't wake up. That may be, you know, a moderate. But either way it goes, you want to address the issue of just not wanting to live anymore. How do we get to this place of not wanting to live, and what can I do to support you? All right, so when you're doing your methods of assessment, your interviews, your written instruments, and your case methods, you want to be mindful of asking very specific questions. So we talked before about closed questions and open questions. In your interviews, you want to do both, but you want to do a lot of direct closed questions. Do you feel helpless and hopeless? Yes or no? Do you feel like you would be better off dead? Yes or no? Do you feel safe in your environment? Yes or no? Do you, if you feel like you were better off dead, do you have a plan to end your life? Yes or no? If yes, what is the plan? What does that plan look like? And so be mindful if they actually have thought it through. And so you will get this kind of information in your interviews. And then you have written instruments. And so some of your written instruments will be the actual assessments that are out there online that they can actually go through the testing of their support level, their helpless and hopeless level. And then the biggest one is going to be the case method. And so the case method gives you a set of 5 skills. These skill questions are going to be good to help you go through the pattern. If you have your textbooks, you can find that on page 169. And so, but the case method, you look at these things. You're going to look at shame and normalizing feelings. I don't have that on the next slide. Shame and normalizing feelings. Behavioral incident, like where is the gun, and gentle assumptions, and what ways have you thought of killing yourselves, and symptom amplification. How much time do you spend thinking about suicide in a 24-hour period? Denial of the specific. And so all these things are outlined in your case methods. And so that's how you'll then get to your treatment plan. And so your treatment plan should be very, very specific to this client. Meaning, you know, I have a gun with 6 bullets. So, you know, let's turn your gun in. You know, there's probably somebody suicidal shouldn't be in the house with a gun and a whole lot of ammunition because they're at greater risk for using those things. So what can we do about that? And that's going to determine your treatment plan. And one big thing that science has shown that it's good and not as useful as we once thought it was is a safety contract. And so it's good because it puts the client in the mind of someone cares that I'm safe. However, it's not legally enforceable, but you want to develop specific safety plan, meaning you want to have a sequence of specific actions the client can take. Meaning if I am feeling helpless or hopeless, I will call my doctor, I will call my mother, I will, call my best friend in another country. I will go outside and go for a walk. I will, and that's back to the gun. If they have a gun, make sure that it's locked up, and maybe they don't have the key. I will make sure the key is with, someone else, a key I can't get to, when I'm feeling helpless and hopeless. And so you want to be specific in your safety contract. Once again, although it's not legally enforceable, it does help the client feel like you care and that at least they have an obligation to you. This is one of the biggest ones I want you guys to look at, which is on page 170, the mnemonics, devices, and the acronyms. And so these are a whole bunch of acronyms that are used. I know some of them look really funny, but they're on page 170, and you can really understand these that'll help you as you're charting and as you're talking to the client. So like number one, is path warm? So the I for is ideation, the S is for substances, the P is for purpose, A is for anxiety, T is for trapped, H is for hopelessness, W is for withdrawal, A is for anger, R is for reckless, M is for mood. So if the client has all of these things in order, then they're probably at a higher risk for a suicide. Let's go down to the bottom one, dead pimp. I know that sounds weird. But the letters stand for D, disorder, E, environmental stressors, A, access to firearm, which we just talked about, D, disinhibition, P, previous attempts, which is really key, I, ideation, M is male, and P is plan. So the reason they talk about males is because at a certain age group, most males are more inclined to want to end their lives, and in what manner than somebody else. All right. Now the last one we're going to look at is we're going to touch on homicide. And so when you look at homicides, especially in the U.S., there's a lot that goes into that. And so it's very difficult for a client to have to a counselor to have to go into a family member's home and give the death notification that your loved one was, was murdered as part of a homicide. There are risk factors. And so you want to make sure that when you go with somebody else. You don't just want to go alone, but you want to go with somebody else, because the risk factors are they could be unbelieving, or they could want to retaliate, or they can sometimes start blaming, again, almost like the suicide. And then when you look at school homicide and violence, sometimes people look at these school shootings and the violence within the school places, and should they have metal detectors and all those things. School homicide and violence is a really, really big thing that happens a lot in America. Our children are innocent, and so oftentimes it'll happen because of bullying, and it happened because of this level of depression that happens within teenagers or someone who wants to cause harm on our school students. So many of the schools that I'm aware of have, now you have to be buzzed in, you have to identify yourself and be buzzed in. I mean, that doesn't help it 100%, but it curbs it a lot. Workplace homicide. Workplace homicide is cute. It's huge, especially if someone is being mistreated at work, and they feel a lot of vengeance towards their boss, and things like that. And so you need to be mindful of what is the workplace environment like. Workplaces can be extremely stressful, and so murders often happen. If someone's fired, they'll respond with going in and killing somebody. And so you'll look at what's the threat level. Talk to them about the threat level. If they're talking about even committing a homicide, referral, you want to make sure that they're in solid and good counseling. And back to threat level, is it a low, medium, or high threat level? What are some of the treatment options? Can you do a lot of preventative steps and a lot of talk therapy? And then you want to look at the survivor needs. When someone has experienced losing a loved one to homicide, that kind of grief is really, really painful, and it's hard for them to get through. And so you definitely want to be mindful of the clients you're going to be servicing, the survivors, the loved ones, and even the community and friends. All right, so that's a broad overview of chapter 6.